Next, we will cover the concept of incentivized HIV care and how it can reduce barriers to access to care. The objectives of this module are to define incentivized care, understand the interrelationship between incentivized and differentiated care, and understand the concept of comprehensive case management as described in PEPFAR's 21 Colombian pesos guidance. HIV care and treatment are crucial to reducing morbidity and mortality among people with HIV, PWH, but even with access to care and support services, some PWH are not engaged in care. New approaches are needed to provide care to persons with HIV who did not engage in conventionally organized HIV clinics. The incentivized care model is a structural health care system intervention designed for the hardest to reach individuals who have the most difficulty engaging in and retaining in care. It lowers all the barriers to care and includes aspects of differentiated care plus open scheduling with walking visits and direct incentives such as bus passes or mobile phone airtime for completing visits or achieving viral suppression. Finally, the incentivized care model includes intensive case management for support for those struggling to remain in care. An example of incentivized care is the Max Clinic, Maximum Assistance, model. The Max Clinic model differs from the standard of care clinic approach in that it attempts to lower all barriers to access. Some key components of the model are walk-in access to medical care 5 afternoons a week, SMS text messaging and direct phone access to individual case managers for those with the most difficulty in being retained in care. The model also includes direct incentives such as food vouchers, bus passes, mobile phone airtime. Finally, the model includes intensified care coordination with individual case management for medical and non-medical issues, a day program for those struggling with adherence and opioid substitution therapy where appropriate. Individual case management is defined as a range of client-centered services that link clients with healthcare, psychosocial, and other services provided by trained professionals. Case management and patient navigation programs help to meet the diverse needs of PLIV in order to facilitate retention in care. The case manager may make referrals, coordinate care with providers and manage the exchange of information between providers and human services organizations. Case management services, which can then be tailored to meet the needs of the community, should include several key elements. Needs assessment, individualized care plan, care coordination, monitoring, ability to reevaluate and change the plan as needed. This is what PEPFAR says in its new 21 Colombian pesos guidance. Further, PEPFAR says that comprehensive case management recognizes that some clients require intensive support while some require just a basic package of care. Comprehensive case management can also be incorporated into differentiated care and be progressive with unstable clients entering the program with intensive needs followed by stabilization and later after ensuring viral suppression transitioning to the basic package of care. Does it work? The answer is yes, with significant increases in the numbers of people who receive the Max Clinic model virally suppressed and engaged in care compared to standard of care. It's me as a person, not me the disease, patient perceptions of an HIV care model designed to engage persons with complex needs. Kristen Bailemas Sophie, Emily R. Bignell, Matthew R. Golden, Allison Moore, Mina Ramchandani, and Julia Z. Dombrowski. AIDS Patient Care and STDs Volume 34 No. 6, 2020. The amount of time we spend at the health facility in the queues, a queue for triage, a queue for the nurse, a queue at the pharmacy and a queue for the labs, it's too much time. I want to come to the facility only twice a year. I have a life to live. Most people are now familiar with the principles of differentiated service delivery or differentiated care. The rest of this module will summarize the general principles of DSD and introduce a short implementation guide for use in your clinic. Differentiated care addresses the when, where, what and who of care with the objective of making access to care easier for clients. Models of differentiated ART delivery can be divided into 4 categories. Healthcare worker managed group models. Client managed group models. Facility-based individual models. Out-of-facility individual models. In all these models, clients continue to have clinical consultations as part of their package of care. The core principles of differentiated service delivery: how it aims to enhance the quality of client experience by putting clients at the center of service delivery. It also ensures that the health system functions in both a medically accountable and efficient manner. The central driver of differentiated service delivery is adapting service provision to clients' needs. Differentiated service delivery is important because it has the potential to improve clients' lives and to improve health system efficiencies and outcomes. DSD supports the scaling up of ART under a treat-all scenario with the goal of reaching the UNAIDS 90-90-90 goals on the path to 95-95-95. Differentiated care is for stable clients whom WHO defines as individuals who have been on ART for at least 1 year, have no adverse drug reactions, no current illness or pregnancy, and are not currently breastfeeding. Stable clients have a good understanding of lifelong adherence and evidence of treatment success, such as undetectable viral load. In the absence of viral load monitoring, a rising CD4 count above 200 can indicate a stable client. As previously mentioned, one model of differentiated care is facility-based. In this model, individuals who are stable are enrolled into a fast-track program. They are no longer required to see a counselor, nurse or clinician and go directly to the facility pharmacy or dispensing room to collect their ART. Clinical reviews are limited to once or twice a year.